Hi guys, this is my first time at video after 35 years at Victor Valley College, but I can really thank people like my wife and Tracy Davis for putting out some good tutorials on this. So the thing that, I can't do, or maybe I can, but we don't have that much time for me to fool around with audiovisual equipment. I might make some mistakes. And if I do, and you're confused about something I said, I want you to give me a call and go, now, did you really mean that? Or did you mean something a little different? And if I messed up, which is more than likely with this thing, um, just let me know. If it's confusing, you read one thing, I tell you something else. I remember years ago, I was teaching medical terminology at Victor Valley High School, and it goes by systems, male, female, reproductive, integumentary, urinary system and so forth. And we just finished the male reproductive system. And then we went into the female. And one of the things I talk about in male is I talk about BPH, benign prostatic hyperplasia, which is an enlargement of the prostate. But the second leading cause of death among males is prostate cancer. So I kind of hit that hard and talked about some of the tests. And right after that, we go into the female, and one girl raised her hand. And so I said, yes. And she goes, excuse me, do females really have prostate glands too? And I don't know what it was. I honestly don't. I don't know whether my copy hadn't kicked in or what. But, everybody was looking at me for an answer. And my brains go, well, they're looking, say something. So I did. I said, yes, they do. And we moved on a little bit. And about 2 seconds later, she raised her hand again. And I thought, oh boy, I'm in trouble. She goes, how come then that you don't hear a lot about prostate cancer in women? And I said, well, you know how CNN is. They just don't talk about something like that a lot. So, and I was heading home and thinking about, the mistake. And I thought, oh boy, I'm in for it now. And I went out with one of the history teachers here for lunch. And he goes, Mr. White, I know you're very knowledgeable on this stuff. He says, you know, how is that uterine cancer in men now? Is that really showing up? And I thought, oh boy, I'm never going to say something like this again. So, you know what? I don't have the answer for everything. But if I don't, I'm going to look it up myself and I'll get back to you. How do I say this next thing with a little bit of objectivity? And that is, this virus is a war. It is affecting all of our lives. And I understand that. And I was reminded about a movie that I really like. It is, probably most of you haven't seen it or never even heard of it, but I kind of like war pictures. Submarine, airplane. Give me a little action stuff, and I like it. When I was in the military, I spent probably 24 months in Vietnam. And, I worried. I thought things could happen here, and I remember flying over to Vietnam twice on a plane. You'd come home for a certain amount of time and go back. And I thought, man, I could die. And I was reminded about this movie, PT 109. It's a story of John F. Fitzgerald Kennedy in the Navy during World War II. He commanded a PT boat, and one of the guys came and got him one day and said, "You've got to talk to this one person, because they're afraid of, that they may not come back. And so when he talked to him, he said, Mr. Kennedy goes, I'm really worried. I feel like there's a cold hand on my heart. And I feel I may not come back. I may not survive. And Kennedy said to him, it's true. You could get killed. This is war. And it's kind of the same thing today. But instead of, when he said at one point, he said after he told him this, he goes, but what can I do? And Kennedy looked at him straight in the eyes and said, well, sorry about that. My grandfather clock is going off. He said, you can do what we all do. You can do your job. As long as you guys are out there, I'm going to do my job and try to help you get through this basic arrhythmia course. And once again, I want to stress something. It's basic. It's not advanced cardiac life support. You should be able to see a rhythm. And number one, you should be able to describe the rhythm to me. That's a heart block. That's a Mobitz 1. Or it's a Mobitz 2. And you should be able to tell me something in sentences about what it looks like. You should also be able to tell me some etiology. What causes this? Now, the textbook goes on for paragraphs and paragraphs. Do we have time for that? No. If we had a year, yes. And I kind of wish we did, but we don't. And who knows when you're going to be looking in an EKG monitor and pick up something about your patient, and you're going to report that to the physician. Maybe by you doing that, that could save the patient's life. Because there's some deadly arrhythmias that can turn sour very quick. So guys, it is difficult. We live in a difficult time. And we're trying like crazy to get an answer to this virus. And I know in one way or another, just from the sheer number of people that has been affected by this, it's somehow going to affect you and maybe your family. And so sorry, I'm trying to get through this first part the best I can. I want you to know I'm here for you. I really apologize, but it gets me. And I know it's going to affect you. So what's the question on your part? What can I do? When you ask that question, I want you to think about nurses, about EMTs, about paramedics, about fire department personnel, about police officers, about the Center for Disease Control in Atlanta, Georgia. We have thousands of people right now working for one goal. That's to save patients' lives. So, what can we do? What can I do besides sit on a video and cry about something? I can do my job, and you can do yours. And once again, I'm here for you. If you just need to talk, I'll listen. And maybe for a good majority of us, patients included, That's a big part of getting well. It's a big part of a fight. So feel free to call me. And I don't care if it's a Saturday, Sunday. Just let's do one thing sometime between 8 o'clock in the morning and 5 o'clock in the evening. I'll listen to you. And if it's a little bit after 5, I'm not going to yell at you. I'm an old person anyways. You could throw something at me and it'd be, 2 years before I catch up with you. So you don't have to worry about asking me something. And people from this class have done nothing but give me respect. And I respect you and I appreciate your time. And I appreciate your effort. And I want you to learn. Now, am I going to teach like other people will teach this same subject with as much knowledge and as much background as they have? Probably not. But, hopefully I can impart to you how to recognize rhythms, how to recognize rates, how to recognize PR intervals, how to recognize QRS durations, and talk to you in the most simplistic way that I can about rhythm recognition and what does that mean for your patients. Well, it seems to have been kind of a little bit of a while since we last met. So I want to recap some things, okay? And what I'd like you to do right now, if you're kind of looking at this video, is to go get this book, the main textbook, EKG Workout by Jane Huff. And I'd like you to open to page 1, Anatomy and Physiology of the Heart. And anatomy, remember, is structure. It's how something looks. How does the heart look? It's about the size of a closed fist. It lies in the center of the chest cavity. It's pointed, in most people, downward and to the left. It has 4 chambers. It has 4 valves. Now, I'm going to be kind of paging through to make sure I don't kind of skip something that I think is important here. The 4 chambers of the heart. The 2 upper chambers are called atrium. Now, I'm about to do something that's going to seem a little bit weird. I've kind of mentioned it in class before. But if I point right here, it's the right atrium. If I point over here, it's the left atrium. You go, well, how can that be? I mean, that's not my right and my left. What I want you to remember is when somebody's talking anatomy to you or structure, I want you to think about the anatomical position. And that is somebody standing erect, the palms of the hands facing forward. And so when they point over on this side, it's the patient's right. Over on this side, it's the patient's left, not your right or left. And when you're looking at an anatomical drawing, which your book has a lot of them, okay, think about the patient facing you. And it's their right and their left. And they're standing erect and the palms of their hands are facing forward. So the upper chambers of the heart, right atrium, left atrium. Lower chambers, right ventricle, left ventricle. Now, if you look at most drawings, the left ventricle is very large. It has the thickest muscle, myocardium, muscle, cardium, heart. It has the thickest chamber in the left ventricle compared to any other chamber of the heart. And the reason is because the left ventricle has to pump oxygenated blood out to all of the cells, the tissues, and the organs of the body compared to any other ventricle or any other chamber. So 4 chambers, right atrium, right ventricle, left ventricle. Now, I'm looking right now, and if you got your textbooks, like I asked you to do, and something to write on, just this isn't court stenography, okay? I'm not going to, have you read back, something to me. I just want you to take notes. Number one, because you're going to turn in that notebook again at the end of the semester. And number two, because I believe by taking notes, you learn. You know, an old saying, I heard it and I forgot it. I saw it, I remembered it. I did it, I understood it. Well, this textbook that's in front of you, EKG Workout by Jane Huff, has over 600 rhythm strips. You're going to fill those out. You go, well, how do I know the answer? They're all at the back of your book. It's real simple. Now, if you ever get to something again that you don't understand, call me. I won't yell at you for calling me. All right, call me. Let me know what it is, and I'll help you work it out. Okay. The right side of the heart, the right atrium, the right ventricle, has one job, and that's to pump unoxygenated blood back to the heart. I'm sorry, back to the lungs, so it can be reoxygenated again. So, and it's called pulmonary, Pulmonary, pulmonary circulation. Pulmono means lung, air, breathing. Okay. So the right side of the heart takes all the unoxygenated blood all over the body and pumps it back to the lungs. And what happens in the lungs? All the airways go down to little bubbled areas called alveoli. And if there was such thing as an alveolar rolling pin, and we could flatten out all the alveoli in an adult's lungs, let me tell you something about that. It would equal 25% of a basketball court in square footage. 25%, that's a large area. But you need that much surface area in order to exchange the unoxygenated blood and pick up oxygenated blood. Now, the left side of the heart also has a very well-known purpose, and that is to pump all that oxygenated blood, specifically the left ventricle that has that thicker area of muscle, to pump oxygenated blood out to all the cells, the tissues, and the organs. And that is called systemic circulation. Systemo means the body as a whole. Okay, you take a med. This is the time for flu, among other things. You take a med like an antihistamine. I'll give you one. Benadryl. There's a good one. It's an antihistamine. How does it affect you? Well, one way that it affects you, anybody in here, I'm sure, has taken Benadryl before, is it dries up secretions, itchy, watery eyes. Okay, scratchy skin, the glands that secrete, liquids and so forth. It dries those areas up. In fact, one thing I want to tell you about Benadryl is a real good side effect. You give that to a child, especially during summer, okay, when the temperatures really peak, yeah. Guess one thing that it dries up that we don't want it to dry up, but it does. It dries up, okay, sweat glands. And those glands, okay, that is responsible for bringing water to the surface of the body, then what? The air hitting that water and cooling you off, that's dried up. And so if you give Benadryl to a child and you send them back out in, real high humidity, those temperatures, and especially a child, are going to peak. And so those are two combinations that can be lethal. You don't want to do that. You want to think about, where's a child going to go after I give them this? Another thing Benadryl does is what? It causes drowsiness. Because histamine, one of the things it does is it keeps you awake, alert. And if you give an antihistamine, you start to drowse off. You're sleepy. Okay? You're lethargic a little bit, depending on how many you take. Okay, so antihistamines not only target itchy, watery eyes and a lot of the respiratory tract and so forth, things that we wanted to target, but it also targets the body systemically. Okay, meaning it's going to affect other areas of the body too. And drowsiness is one of those effects. It's what effect? It's a systemic effect. Yes, we wanted to target the nose and respiratory, area and so forth, but it also hits the entire body. So if I mention drugs, which I'm going to, especially cardiac drugs, realize that it has a systemic effect. It affects the body as a whole. Okay, so once again, just to recap, right side of the heart, pulmono, pulmonary circulation, pumping unoxygenated blood back to the lungs in those little tiny spaces that kind of look like grapes, alveoli, and the blood becoming reoxygenated. And the left side of the heart, pumping bright red oxygenated blood out to the entire body. Now, we've gone over circulation, but if you're kind of hung up on that, well, then I've got a little video that you can look up. You remember, well, some of you do, the picture Happy Days. Well, in Happy Days, they went off to college. And one of the tests was, in college, biology or physiology, one of the tests was trace blood, a drop of blood, through the heart. You know what they did? They wrote a song about blood through the heart, about blood flow. And it's right on. So if you look up Happy Days, blood flow through the heart, you're going to find that. Just listen to it. I mean, it's kind of fun. Okay. And they all got perfect papers on that. And the professor actually accused a lot of students of cheating because he said, how can you get a perfect paper? And he goes, we wrote a song about it. And sometimes, especially in this course, you have to do kind of peripheral things in order to get centered. Now, we also talked about the layers of the heart. And we talked about the inner layer, the endocardium, endo within, cardium, cardio, heart. So the layer that lines the inside of the heart also lines the heart valves, okay? Covers those valves. And right next to that endocardium is the next layer we run into is the myocardium, or the muscular layer of the heart. And then we run into, and this gets a little confusing, pericardium. Peri means surrounding or outer. So the pericardium is kind of an outer double-layered sac. In this case, sac spelled S-A-C. Okay. So this outer layer, this pericardium, has a couple of parts to it. One is called the fibrous pericardium. Well, the fibrous pericardium is the very outer layer. It's a tough fibrous sac and it surrounds the heart. And then we hit the serous pericardium. Kind of looks like Sirius, but serous pericardium. And the serous pericardium has a parietal layer. And the parietal layer is the inner lining of the fibrous sac, the fibrous pericardium. So if you would open up the pericardium, that's the serous pericardium. It's the inner surface of the fibrous sac. And then we hit the visceral layer that lines the outer surface of the heart muscle, the myocardium. Okay? And between these two layers is kind of a cavity. And this cavity is the pericardial space. And this cavity has fluid in it, pericardial fluid, somewhere between 10 cc's of pericardial fluid and 30 cc's. And what happens is this gives room for the heart to contract and to expand, to contract and to expand. Okay, so the fibrous pericardium is an outer tough fibrous sac. And then we hit the serous pericardium, and the serous pericardium has a parietal layer that lines the inner surface of the fibrous sac, and it has a visceral layer that lines the outer surface of the heart muscle, the myocardium. And between these two layers is a space, okay, the pericardial space. So we have the endocardium, the myocardium, okay, and then we have the fibrous pericardium. Okay. Well, actually, if I'm doing it that way, we hit the serous pericardium and we hit the visceral pericardium. Serous pericardium has two layers, parietal layer, if you look on page 2 of your textbook, and visceral layer. The myocardium is the muscle layer. That when you think of the heart, you need to think of two kinds of cells, primarily. You have mechanical cells, and mechanical cells are the muscle cells, the myocytes. Myo means muscle, cyte is cell. And we have electrical cells. So if you go back to biology or some of the courses we took in high school, maybe, and for some of us, and some of the courses we took in college, here comes the professor with a frog leg. And what's a frog leg doing? Nothing. Is hanging on a little pole here. Okay. And the prof puts this in front of the class, right? And he takes a little electrical pin or stimulator out of his pocket. And he stimulates these muscle cells. And what do? They jump. They contract. So electrical cells stimulate muscle cells to contract. Again, that's a very important concept. Electrical cells stimulate muscle cells to contract. Okay. So the heart not only has 4 chambers, it has 4 valves. Kind of in a golf game here, okay, 4. Okay, and the valves are, 2 of the valves are between the atrium, the upper chambers of the heart, and the ventricles, the lower chambers of the heart. And the one on the right, between the right atrium and the right ventricle, is called tricuspid because it has 3 flaps, 3 cusps. And so when the atrium contracts, the right atrium contracts, blood goes through the tricuspid valve down to the right ventricle. And when the left atrium contracts, blood goes through another little valve called the bicuspid valve. It has 2 flaps or 2 cusps. And it goes down to from the left atrium to the left ventricle. Now when the right ventricle contracts, blood goes up through another little valve called pulmonic or pulmonary valve. And right above the pulmonary valve is kind of a T-shaped, looking structure. That's the pulmonary artery. And the pulmonary artery, and this is going to sound a little strange that I'm saying this, because arteries usually carry what kind of blood? Oxygenated blood. Well, the pulmonary artery, it carries unoxygenated blood back to the lungs. In the heart, there's a little bit of reversal between arteries, what arteries do normally, and what veins do. Okay. When the left ventricle contracts, at the top of the left ventricle is the aortic valve. Okay? And so blood goes from the left ventricle through the aortic valve and out into the system. Okay? What system? The systemic system, the entire body as a whole. Okay, once again, between the right atrium and the left atrium, there's valves. On the right side, tricuspid. On the left side, bicuspid. Okay. When the right and left ventricles contract, because the atrium, when they contract simultaneously, contract together. And ventricles, when they contract simultaneously. They contract together. So the main thing I want to get to you is between the right atrium and the left atrium are called, you gotta give me a little bit of credit here, but give yourself a little bit of credit. Because it's a little hard concept, but look in your book, page 3, okay, are these valves. Right atrium, left atrium. Okay, right atrium, tricuspid, left atrium, bicuspid valves. Okay. And they're called, I don't know how they came up with this, just listen to it. They're called give me 1 second here. This makes me a little nervous because there's hard to, this is the first video that I've done, and it, being on a tape here is a little bit difficult. So they're called atrioventricular valves. What is? Tricuspid on the right, bicuspid on the left. Atrioventricular valves. Standing between the two are these flaps, these valves. Now, when the right ventricle and the left ventricle contract, right ventricle, blood goes out the pulmonic valve. Into what? That T-shaped structure, the pulmonary artery. And once blood is reoxygenated in the lungs, there are 4 veins that come back to the left atrium. And they're called pulmonary veins, except these veins are carrying oxygenated blood back to the left atrium. Okay, so 4 chambers, 4 valves. Now, would I ask a question on some anatomy of the heart? Probably. How big is the heart? About the size of your closed fist. Unless there's some pathological thing going on, like congestive heart failure, which can easily enlarge the heart. Okay? And we'll maybe talk about that at a different time. Now, lying on the outside of the heart are arteries, and they're called coronary arteries. And they supply the heart itself with blood and oxygen. So the idea here is that the heart not only pumps blood and oxygen to the rest of the body, to the lungs, and systemically as a whole, but it has to get blood and oxygen itself or it dies. Well, because of all the great diets we're all on, if you watch the news now, you see a lot of it advertised. Okay. I'm glad McDonald's is still allowing it. We're filling up those arteries with what? With plaque, almost like rust in a pipe. Okay. And blood takes a while to go through there, and the more we fill it with this plaque, like rust, we narrow those arteries. Atherosclerosis. Fat that we pick up from where? All over the place. Here, I'm going to say a word. I'm going to whisper it because I don't want anybody to hear. Eggs. You hear? Eggs. Eggs have a lot of cholesterol. Milk. Listen, you want milk that's low in cholesterol? Go get yourself a couple of drops of whiteout. Put it in a glass of water. The cholesterol can be low. I probably don't want to drink milk like that. Okay, but, some people do. Okay, so fat is plugging up those. And it's kind of, if you want to give a color to this, it's kind of like going, look, here's the inside of the artery. And plaque is kind of this yellowish plaque. Okay, and it narrows the vessel. And eventually that plaque is going to get a little crack in it. And when that happens, okay, that little crack, what happens is that you get a blood clot, a thrombosis. Now, thrombo means blood, and osis is an abnormal condition. We want blood to clot, but not in those arteries, because once you get a clot in those arteries, what happens? The layers of the heart begin to die. And let me tell you something about that. They die from the inside out. Okay, inside out. So we've got these coronary arteries, and now I'm looking at page 5, okay, of your textbook. We got these coronary arteries. You can see them kind of like right here. Okay, and they're lying on the surface of the heart. And they're trying to get blood from the outside of the heart to the inside of the heart. Well, that's a tough job, especially if you eat a lot of French fries, go to McDonald's, and you buy yourself some steak or whatever. And don't misunderstand me. I have terrible diet. My wife tells me about it all the time, but you get that blood clot. And that blood clot does what? It causes, number one, ischemia. What's ischemia? It's a temporary reduction to the tissues of the heart. Okay? Temporary. Am I the only idiot that's probably ever done this? You ever tied something around your wrist really tight? Kind of like a tourniquet, but different, right? Or around the bottom of your finger, like a rubber band. And what happens if you look at your finger there for a couple of minutes? It begins turning blue, cyanotic, cyano, blue, otic, pertaining to. Bluish discoloration is because the organ is not getting enough blood and oxygen. How do we know that? Are we going to look at the finger? Well, we could. That's one of the reasons when you go to surgery, ladies, they don't want you wearing nail polish. Why? Because the anesthesiologist looks at nails. He looks at when he pushes in, they kind of blanch out. When he releases, we're looking at something called capillary refill. Okay, and if there's something that makes the artery narrowed, okay, especially the blood clot, and you have ischemia, you've got to release that, right? You've got to release that constrictor. And now the way they do that today is quite a lot of things. They can do a bypass on the area. Coronary artery bypass graft. Let me say that again. Coronary artery bypass graft. What is it? Cabbage. They called me a while back, one of the hospitals. I mean, I didn't know what to think of this initially, and they thought, well, would you come in and talk to our secretaries about medical terminology? My first question was, why? Why do they have to know medical terminology? Well, if we order a cardiologist to come in and we say we might do a cabbage, what the heck? Do we want them to go down to Stater Brothers, get some corned beef too? No. So they have to know what it means. Okay. And, they have to know what cabbage is, and they have to know what a stent is, like taking a spring almost like out of your pen, and putting it inside of one of the coronary arteries, and it pushes it back open again so that you reestablish circulation. Okay, so that coronary circulation is very important. So you come up with what? Ischemia. Now go on for a little bit while. What if you leave the rubber band on your finger? Ischemia. Okay, if you're stupid, well, I shouldn't say stupid. If you're a little bit like I am part of the time, you've got a little bit of, I always tell students I'm a couple of tacos short of a combination plate at times. Like I told the girl, yes, women have prostate gland. Oh, hello. Okay, so, you need to review this stuff over and over again. But you need to open that passage by detouring around it, that blood clot. Okay, so ischemia is first, then injury. Injury. An injury is like a wound to the tissues. Cells, trillions of them, make what? Tissues, like epithelial tissue or adipose, fat tissue, or cardiac tissues. Tissues make organs, like the heart, the lungs, the kidneys. And organs put together in the right manner, okay, make body systems. Cells make tissues. Tissues make organs. Organs make body systems. And I think the more you get into physiology, the more you get into anatomy, you're going to find out that this body that we live in is pretty amazing. Now, I don't care what you believe. My personal opinion doesn't mean a lot anyways, but, some people, they're going out there on the edge, for what they believe, and that's fine. If you want to go on the edge with me, that's fine. I've had professors that do it. One of them down at Cal State, I won't say where, had his doctorate's degree. And he got up in front of a class one time and said, you know what? Babies in utero have as much brain cells as a puppy dog. And I looked at him like, and his whole class did, like, what? Now, if I get up here and say something like that, I'm sure you say, where are you going with this? Well, I knew where he was going. But seriously, I'm going to get up in front of a class and say, babies in utero has as much brain cells as a puppy dog? I don't think so. Okay. So we go from ischemia into what? Into injury, kind of like a wound to the tissues. And we go to the third eye, infarct. Ischemia, injury, infarct. And that's what happens over a period of time. But you got to understand one thing. If we get you too late, there's nothing we can do. Nothing. Why? Because the damage has already been done. And you're going to see on the EKG where it tells us whether, a lot of times doctors run an EKG. And by the way, if we're running it, we do a what? 12 lead EKG. And I want you to think of a lead as a camera angle. It's looking at something from 12 different angles. It was kind of funny, but I went into a medical office one day and my medical assistants were in there. And I said to one of them that worked there, I said, can I borrow one of the charts off the wall here to, show one of my students or a couple of them what a 12 lead EKG looks like. And the guy looked at me like I was saying, speaking foreign or something. And I said, a 12 lead EKG. And he goes, we don't do those here. And I kind of laughed and I said, no, seriously. I'll return it. I promise you. I'll put it back myself. It won't be misplaced. Can I borrow a 12 lead EKG? He goes, we don't do 12 leads, Mr. White. And I'm going, well, they do in San Bernardino. Do we do something different up here in the high desert? He goes, Mr. White, think about how many electrodes we put on the patient. We only put 10. Right? One on each arm, one on each leg, and 6 on the chest. It's 10. 6 and 4, 10, right? And I go, okay. So we only do 10 lead EKGs. And I'm going, uh-oh. Somebody's missing the point here. The machine, the electrocardiograph, changes angles internally between the leads. It does it on its own. I said to another girl that goes out and does blood work for insurance, I said, you do 12 leads, right? She goes, what do you mean? Well, 12 lead EKGs. She goes, I'm not sure what you mean. Okay, from now on, if I say a 12-lead EKG, you think of 12 different angles. Of what? Of the heart's electrical activity. And why are we looking at it from 12 different angles? Because what looks good in one angle will look bad in another, maybe. So we have to see it from 12 different angles. Like I told you guys on one of the lectures, I said, what if I sold this video up here, the sound and the computer and everything for $5? Any takers? And several of you raised your hand. I go, really? From where you're sitting, you would buy this for $5. Well, no, not without what? Without looking at it from different angles. Well, somebody buys a car. What do? They get under the car and they look for oil. Okay. Why? Because again, sitting on a lot, that's one angle. Going around it, getting under it, looking at it from all different angles. So when we think of a lead, we think of an angle, a camera angle. Police officer walks by the bank. Everybody in the bank smiling, waving, right? What's going on? Oh, they're all smiling. They're all happy people. From what? From his point of angle. From his position, that's what he sees. But if you'd walk around maybe to a different angle, you'd see a guy with a gun maybe pointing at somebody's head, go smile. Okay. So we do 12 leads. I mean, we could call it a day, we could do one lead. And by the way, just so you know, if I want a quick readout of the rate and the rhythm of the heart and what's going on with it, what kind of rhythm it is, whether it's tachycardic or bradycardic, I could do a lead 2. A lead 2. I want you to remember that. And lead 2s, print either at the bottom of the gram. The gram is a picture. The electrocardiogram is a printed picture. You'll do something and look at it, it's a gram. You get something to run it, it's the graph. If you're running it and taking the pictures, that's ography. Ography, you're doing it. Electrocardiography. Electrocardiogram, I'm going to give you a piece of paper. You can look at all 12 leads. But lead 2 runs all the way through this. See, the rest of the leads are just little short clips of what it is. But a lead 2 is very diagnostic. Okay? Gives you a quick readout of how the heart looks, of what rhythm it is, what rate it is. What do we have? We had ischemia, a temporary or transient deprivation of blood to the tissues of the heart. We don't deal with it. You're a guy, you take a shot of Jack Daniels, go to bed. You call it a night. Honey, if it's like this in the morning, I'll go in. That's a typical guy thing. No pain, no gain. Well, I don't know. One guy years ago over here in Asperia was screaming at the paramedics when they came across the field. It's not my heart. It's not my heart. It was. He died right there. Denial is a big thing. Very, very important with the signs and symptoms of a heart attack. So you go from ischemia into injury, which is kind of like a wound of the tissues, into infarct, death, MI, myocardial infarction. But what I want you to know about that is we're just saying the myocardium, we're actually saying all of the layers all the way through. And that's, if you look at all the way through the heart, it's a transmural. Trans means through. Mural means all those layers, those walls that we stacked up. Okay, a little bit of electrophysiology. So I said there's 2 important cells when it comes to EKGs. One of the important cells are the muscle cell. And I look at the muscle cell, maybe somebody else will look at it differently. It's okay for me. There's a lot of ways to teach, all right? But they would look at it as a mechanical cell, and that's the way I look at it. It's going to do something. It's going to perform a function. What's it going to do? It's going to contract, okay? And then there's the electrical cell. So the teacher touches the frog leg, and the frog leg what? Jumps and contracts the muscle. Now, the inside of the cell has a very important electrolyte in it, and that's potassium. And potassium is the major intracellular electrolyte. Okay? And then it has sodium on the outside. So potassium inside and sodium on the outside. Okay? Now, potassium gives the cell a negative charge on the interior and a positive charge on the surface. And what do we say when that is? When we look at a cell that's polarized, it means it's charged. Okay? And a polarized cell is in a resting state. Once again, it's the frog leg. It's just hanging around. It ain't doing anything. Okay? And on the inside of the cell, we have potassium. And on the outside of the cell, we have sodium. Then what? The cell depolarizes. What does that mean? It means sodium goes to the inside and potassium exits. And then what happens? When depolarization is complete, the interior of the cell is positive. The exterior of the cell is negative. And then what? Repolarization begins again, and we call repolarization the recovery state. So polarized, it's a resting state. The cell ain't doing much. It's resting. It's hanging around. Depolarized, the cell is stimulated. And what happens during that? Sodium goes in, potassium comes out. And when it repolarizes, potassium goes in and sodium comes out. When you think of an electrical stimulus hitting these areas, I want you to think about the polarized cell. And then I want you to think about depolarizing. And when it depolarizes, it contracts. And then what? It repolarizes. What's that mean? Well, what it means is when it repolarizes, that's the recovery state. Okay, and during the recovery state, potassium goes back in and sodium comes out. Now, when we look at the electrical conduction system of the heart, I'm looking at page 10 here. You can see all these drawings here. Okay? When we look at it, what's the first area of the heart we look at? We look at the SA node. And anytime somebody says SA node or sinus node, that is the main node of the heart, so to speak. Why? Because the SA node will set the rate and the rhythm of the heart. And then what happens? The electrical impulse goes out from the SA node, almost like dropping a pebble in a pool of still water. Okay, what happens? You get all these concentric rings coming out. And when you drop a pebble where the SA node should be, you get all these concentric rings coming out. And from the SA node, that sets what? The rate and rhythm of the heart. The positive charges go from the SA node down to the AV node, the atrioventricular node, which is kind of, if you will, the next area. So between the sinoatrial node and the AV node, there's like 3 wires. Let me say that again. Between the sinoatrial node and the AV node, here's the sinoatrial node, here's the AV node. We've got to have a way to get the electrical signal down here from here, okay? And we have 3 wires, almost like neural pathways. And those are called internodal tracks. What's inter mean? Between. Nodal. What's that mean? Well, here's the SA node. Here's the internodal okay, the AV node. So we've got to get kind of signals going from the SA node down to the AV node. And those signals are from internodal tracts. And those tracts are the one in front, the anterior internodal tract, the middle internodal tract, and the posterior internodal tract. And then we've got, remember this, running from the AV node over to the left atrium? We have what? Bachman's bundle. I don't know why, it just sounds like a brand of gum to me. Beecham's, Bachman's bundle. When you look at the SA node and the internodal tracts and the AV node and the His bundle and the right and left bundle branches and the little wires that stick out from there, okay, the Purkinje fibers, that's going to bring the electrical charge all the way down to the ventricles, and then the ventricles are going to contract. So the first thing that happens is atrial contraction. So the atrium, if you will, when they contract simultaneously, both the right and the left, come down from the SA node to the AV node, and then the His bundle, and then the right and left bundle branches, and then the Purkinje fibers. Okay. And out of this, if you look over on page 11, we have waves that are set up. And at the top of page 11 on the right is the P wave. And what does the P wave tell us? It tells us atrial depolarization and subsequent contraction. Let me say that again. Atrial depolarization and subsequent contraction. Okay, as soon as you look at the P wave, we go for the QRS. Now, when you're looking at an EKG, you don't really want to see large Qs. You don't, most of the time, don't want to see any Qs at all. Why? Because Qs represent infarct, okay? Death to areas of heart muscle. So you want to see a P, and after the P, there's about a 1/10 second pause. I'm looking at page 11 right at the top right, okay? You see a 1/10 second pause, and what's that do? That lets us get blood from the atrium down to the ventricles through the AV valves, tricuspid on the right, bicuspid or mitral on the left. And then we see the QRS. And the QRS tells us about ventricular contraction. And then we see a little flat piece of baseline, and then we see the T wave. P, QRS, and T. P, QRS, and T. So the P wave, once again, represents atrial depolarization and subsequent contraction. The QRS, ventricular depolarization and subsequent contraction. Right after the S, you see a little flat piece of baseline. I'm looking again, page 11, right up to the upper left. You see a little flat piece of baseline, and then the T wave. And the flat piece of baseline is called the isoelectric line. Okay? And you see that, you see where it says positive deflection? Page 11, right up at the top. Positive deflection. Let me tell you something now, and it may not make a lot of sense. When a positive wave moves towards a positive skin electrode, there's a positive upward deflection on the EKG. Because a lot of people look at EKGs when they first, begin to learn them, and they go, how come part of these are above the line, kind of going up, and part of them are below the line? Well, I'm not back there pushing a button trying to confuse you. As a positive wave moves towards a positive skin electrode, there is a positive upward deflection on the EKG. Now, at the same time, as a positive wave moves away from a positive skin electrode, there is a negative deflection on the EKG. And that's why some of the waves look positive, and that's why some of the waves look negative. So the baseline or isoelectric line could be above or below the baseline. But once again, as a positive wave, positive from where? The sinoatrial node. Leaving what? The SA node. Where? In the posterior wall of the right atrium, near the opening of the superior vena cava. As this little node sets the rate and the rhythm of the heart, it sends out positive electrical signals. And we'll talk about that more in a moment. Okay. Now you notice also on 11, you have positive deflections, negative deflections. And then take a look at this, biphasic deflection. You're going to see these. You're going to run across them. And what's biphasic mean? It means that you see that the QRS, how it looks there under biphasic deflection. Okay, part of it is positive and part of it is negative. Okay. All right, I'm looking. Now I want you to look over on page 12 of your main textbook again. Okay, and we see some waves. We see a P wave, which represents what? The P wave represents atrial depolarization and subsequent contraction. Now, in reality, contraction lags a little bit behind depolarization. But every time you see this bump, a positive bump there, okay, usually in lead 2 is a good place to, once again, look at the waveforms. The P wave should be positive. It should be above the isoelectric line. And then what do we see? We see a little bit of a negative Q there. And then we see an R. We don't even see any S wave. And the QRS represents what? Ventricular depolarization and subsequent contraction. And then, are you seeing this thing that says absolute refractory period? Notice where they draw it from. The beginning of the QRS. Now why? Because we have a Q wave. Usually I don't even want to see Q waves. But if the Q wave is big enough, if it's significant, we'll talk about that later, kind of really stands out, then there could be an infarct going on, and that's not a good sign, okay? So we see a QRS represents what? Ventricular depolarization and subsequent contraction. So from the beginning of the QRS to the middle of the T wave is what? Is something called absolute refractory period. You know what that means? It means the cells of the ventricles have not fully repolarized yet, and the heart is not going to conduct an electrical impulse from anywhere. Remember I told you these electrical impulses, these ectopic impulses, ectopic occurring in a place other than normal, they can happen at any time you get low oxygen. You can get an irritable ectopic focus firing. When it comes to the ventricles, usually low oxygen steps in, hypoxemia, okay, low oxygen content. But from the beginning of the QRS to the middle of the T wave, we see this absolute refractory period. What does that mean? If an ectopic focus somewhere in the heart becomes irritable and fires, okay, the heart's going to ignore it. It's not going to conduct it into some very dangerous arrhythmia. Like what? Torsades. Torsades de pointes is a type of ventricular tachycardia. Some high waves, some low. Some high, some low. And what it means in French is twisting of points. Twisting of points. It looks like a twisted party streamer. And a lot of people, when they look at this, okay, torsades, think it's probably 2 ectopic foci. One firing high waveforms, one firing low waveforms. Well, torsades can happen up to 350 beats per minute. Now, here's something I need to tell you. What's normal rate of the heart? 60 to 100 is normal rate. A lot of people say, well, okay, 72. They just, go down to the low 70s and they say that's the normal rate. But anywhere between 60 to 100 is normal. You start firing at 350 times per minute. What else do we talk about in a couple of lectures? We talked about preload. What is preload? The atrium fire, okay, depolarize, and blood goes through part of this by gravity down to the ventricles. Through what? The AV valves. Tricuspid on the right, bicuspid on the left. And then what happens? Okay, that rings. It gets my brain. let me wait here just for a second. Let it stop doing its thing. It's good we're on 3 o'clock in the afternoon. Okay, because once it chimes 3, I can continue. Here we go. Does anybody know any good chime jokes? Whatever. All right, so we have absolute refractory period go from the beginning of the QRS, either the beginning of the Q if there is one, or the beginning of the R, to the middle of the T. And that means if an irritable focus fires atrial, junctional, or ventricular. What does that mean? The SA node has 3 levels of backup. So that 3 redundant levels. And if you're sitting around having a margarita in your dip, here's what's going to happen. If your SA node just stops firing, you've got 3 redundant areas, backups to the SA node. In order, atrial, ectopic foci. Why do I say ectopic? Because if an atrial focus starts firing, and it fires, going into some kind of a rhythm, an atrial rhythm, it's going to fire somewhere between 60 to 80 beats per minute. 60 to 80. So one way to identify what's going on with the heart, who's firing, is by the rate alone. If it's like 80, okay, 60 to 80, it could be, okay, an atrial ectopic focus. But remember I told you before, if it becomes what? Irritable. It could be meds the patient's taking. Coffee, Coca-Cola, why does everything start with a C? Cocaine, there's a good one. A guy pretty high up there in workforce told me, oh yeah, I've tried cocaine, but I know how much to take. What? And I'm not going to tell you what this guy did, but he was in EMS, okay, and he was very high up. And he said, yeah, I know how much to take. So, and that's why you see me never drunk when I drink. And when I take some cocaine, I know how much to take. What are you, brain dead already? Hello. Okay, you've got a master pharmacist up here in the brain. And what's he doing? He's handing out chemicals. You start acting like your own manufacturer of these chemicals, you're going to get in a lot of trouble very quickly. So atrial ectopic foci fire between 60 to 80 normally. Okay, but in the case of torsades, it can fire up to what? 350 beats per minute. That's pretty fast. And what does that mean? You don't have enough preload. You don't have enough filling. What is preload? At the end of diastole, what's that? Systolic is the ventricles in a state of contraction. Diastole is the ventricles relaxing. Everybody says, yes, systole and diastole is part of a what? Is part of, the blood pressure. Top number systolic, bottom number diastolic. Well, that's true to some degree, but systolic and diastolic come from phases in the cardiac cycle. When you look at diastole, the ventricles are relaxing. When you look at systole, they're contracting. So when you look at preload, it's like taking a balloon, going over to the faucet, tying it around the faucet, and turning on the water and letting it fill. in reality with blood. So think about that. So you turn on the water, the balloon fills. In reality, you turn on the blood and the blood fills. Okay. And at the end of filling, so end diastolic volume, how much blood is in the ventricles at the end of filling? Okay, that's preload. Okay, how much? Now, if you get a real fast rate, a tachycardic rate, remember tachycardia is anything over 100. But what are we talking about? We're talking about somebody that becomes irritable. It just shouts something out all of a sudden and starts firing. So this focus, atrial is first. It's the first backup to the SA node. Yeah? Okay, normally it can fire between 60 to 80. But during times of low oxygen, medications, a little cocaine on the side, yeah, it can fire real fast, 150 to 250 beats per minute, and in some cases 350 beats per minute. Well, look, if you're firing 350, that's like 5 contractions per second. How much time do the bottom chambers of the heart have to what? To fill? Not very much. And so what's going to happen? You're going to go into a syncopal episode. What's that mean? You're going to faint. You're going to pass out. You're going to hit the floor. Boom. Okay, what's the second backup? Junctional. What's the rate on junctional? We see a rate and we go, is it atrial or junctional? Well, junctional fires between 40 to 60 beats per minute. And when you look at a junctional focus firing, I'll give you one big hint. Not that you get this all in one lecture, but here it is. I kind of want to end the class. No, give you a couple more sentences and give you the final. Now, junctional is between 40 to 60 beats per minute. So you have a rate of 40 to 60, you could maybe say it's junctional. But what's another thing that tips it off as junctional? Junctional has inverted P waves, upside down P's, inverted. So instead of when you look at lead 2, a positive deflection above the isoelectric line, you've got a negative deflection, an upside down deflection occurring. Well, once again, this can happen anywhere between 150 to 250 and then sometimes the 300 range. Yeah, so you need to kind of identify where is this coming from. Okay, inverted P's are not normal. P's are normally positively deflected above the isoelectric line, above the baseline. How do you get a baseline? You look at the PR. You take a piece of paper, you put it to the bottom of the PR. That isoelectric line should go right in the center of everything else. Once again, any deflection above it is positive, any deflection below it is negative. Okay, the next backup we have to the SA node. Remember, the SA node is a sinoatrial node. It is in charge, usually. It sets both the rate and the rhythm of the heart. The last backup, the last redundancy system we have is ventricular. And ventricular system is where? Down in the ventricles, obviously. Okay, so when the ventricles fire, they can fire between a rate of 20 to 40. Notice we're getting slower each time. And the other thing I want to impress upon you is we get to a really slow bradycardic rate. Preload goes down, which means what? Afterload goes down. Okay. Everything goes down when that happens, like torsades. You don't do too well on 350 beats per minute, 5 contractions per second. That isn't, really well. You're not getting enough perfusion. Perfusion is a word that means blood flow. Okay. All right. 20 to 40. So we've got 3 backups. Atrial, 60 to 80. Junctional, 40 to 60. Ventricular, 20 to 40. But any of those areas, and there's multiple ones, there's multiple atrial ectopic foci, ectopic occurring in a place other than normal, like an ectopic pregnancy. Okay, the SA node should depolarize and set the rate and the rhythm of the heart, not a focus in the atrium. not a focus in the junctional, not a focus in the ventricular. Atrium's in charge. But sometimes, and that, what I just said, is a very important concept, and it's called overdrive suppression. Let me say that again. Overdrive suppression. Whoever drives the heart at the fastest rate is going to set the rate and the rhythm of the heart. And once again, in an ectopic area, any of those can pop up. Normally the SA node is, 60 to 100, but another ectopic focus, because it's irritable, can start firing at 250, 350. And what does that do? That overdrive suppresses all the other areas. So the one that drives the fastest is going to be the pacemaker. Usually it's SA, but you get an irritable focus like an irritable student. Okay. And I've had a few, and you guys are not irritable to me. You're a blessing. You really are. So you got those three areas of backup. I'm sorry, I don't think I've ever been this emotional on a lecture, but on occasion it happens. All right, so I have a margarita and continue. No. So I'm looking at page 12. And what do we have? The absolute refractory period. Where is it? From the beginning of the QRS to the middle of the T. Beginning of the QRS to the middle of the T. That means what? It doesn't matter how irritable the focus is. The heart is not going to conduct an irritable focus if it's anywhere from the beginning of the QRS, which is the beginning of the Q or the beginning of the R, whichever you see first, to the middle of the T. Now, from the middle of the T all the way down to the end of the T is what? The relative refractory period. Now, the relative refractory period has been called a vulnerable area. Vulnerable. What's that mean? If a strong enough electrical signal coming from an irritable ectopic focus fires, the heart's going to run with it. From where? The middle of the T till the end of the T. Relative refractory period. And it's been around for years. There's something called an R on T phenomenon, where anywhere from the middle of the T to the end of the T, relative refractory period, if you get the R on T, the heart can start going nuts. Can go up to 350 beats per minute. And an irritable focus take over. So one of the things here is what? I told you guys to look at the QRS and to measure it. And what is normal QRS? 0.10 or less, 0.10 or less. And one of the things you don't want to do in medicine is put a point and then a 0 and a 1 and a 0. You don't want to do that. You go, why? Well, how do you know the point's there? We're not reading Braille here. There's not a bump on the EKG to tell you that point is there. So anytime you're going to write point something, put a 0 in front of it. Let's say that again. Anytime you're going to write 0.10, put a 0 in front of it. 0.10. 0.10 or less is the relative, okay? Well, 0.10 or less is normal QRS duration. Now, what if it's stretched out? What if the QRS duration is 0.12? Well, that's interesting. It's 0.12, so it's beyond normal. And people go, well, yeah, that's borderline. Borderline? We try not to use in medicine the word borderline. It's like being borderline pregnant, excuse me, you are, you're not. Let's get off of this borderline stuff. Okay, 0.12 is above norm. Normal QRS duration from the beginning of the QRS to the end of the QRS. Let me say that a little bit differently. Something I taught you guys earlier. From the beginning of the QRS to the J point. What's the J point? Well, it's where the QRS ends. What does that mean? Well, sometimes if there's an S, the S comes back up, right, and levels up. At the point where it comes back up and just starts to be horizontal again, that's the J point. Okay, so when you measure QRS, you need to measure it from the beginning of the QRS to the J point. Now, the ECG has graph paper under it, right? And it's running like, here's a good one, a roll of toilet paper. Okay, very interesting. Let me tell you something about graph paper on the EKG. Never leave it in the sun. Never leave it in the bathroom when you're taking a shower. Why? It's heat, light, and pressure sensitive. I put one on my dashboard once and went in. I took it around to show students, and it's very interesting. I said that, well, here it is. And I looked after I came back to my car and there was no EKG. I went, well, where did I put my EKG? So it was on the dashboard. It just, all the waves had disappeared. Heat, light, and pressure sensitive. You don't want to be able to scratch it or you think, something else is going on. Also, when you look at EKGs, look at artifact. Somatic tremor, soma, body, tremor. They're shaking. Why? Because they're afraid. They don't know what you're going to do. Right? They have no idea what you're going to do. Okay, you put a bunch of metal on them and some wires. Now you plug the doggone thing into the wall. Whoa, no, we're not going to shock you, sir. We're just going to take some views, some camera pictures of your heart. Probably the easiest thing to say. They're not going to receive a shock through the electrical wire. Okay. AC artifact. AC, alternating current artifact. You have a big machine in the room. It's not properly grounded. The waves look very thick and peaked. That's alternating current artifact. Wandering baseline. The baseline goes like a roller coaster all over the place. Okay? So wandering baseline, AC artifact, and somatic tremor are the three interferences to an EKG that you want to keep in mind. You want to try to calm your patient down, before you run the EKG. Okay, so now I'm on page 13. Waveforms, intervals, segments, and complexes. The P wave. From the beginning of atrial depolarization to the end of ventricular atrial depolarization. Beginning to the end. Okay. Now, remember again, it originates in the SA node. SA node throws out positive charges, between 60 to 100 per minute. It sets both the rate and the rhythm of the heart. So what should you be looking at? Sinus. And if you're looking at something sinus, usually speaking, then the morphology, how waves look, the structure of what you're seeing, they should all look the same, which means what? They're all coming from the same spot, which means they're all coming from the same focus. Usually, yes, I know. Now, the other thing that I told you, if you recall, is I talked about the PR interval. The PR, what is that? The beginning of the P to the beginning of the R. And it's called the PR interval. And what is it normally? 0.12 to 0.20 seconds. 0.12 to 0.20 seconds. How do we look at that on EKG? A little block, one little tiny block on an EKG is 1 millimeter high and 1 millimeter wide. Okay. And on a horizontal axis on an EKG, it's a measurement of time. And each little block is 0.04 seconds wide, 0.04 of a second wide. And let me tell you something else about what I just told you. How fast is that paper coming out? 25 millimeters per second. Now, an interesting little mathematical equation here. I don't know if anybody loves math. I personally don't because I'm not good at it. Okay, so I've got to read something over and over again and, kind of take a look at it. But 0.12 to 0.20 seconds is normal. And what does the PR represent? The beginning of atrial depolarization and subsequent contraction. See that once more. The beginning of atrial depolarization and subsequent contraction to the beginning of ventricular depolarization and subsequent contraction. PR, the beginning of the P to the beginning of the R. Okay? Called the PR interval. Okay, and you can have a prolonged or you can have a short PR interval. But it should be within normal limits if everything is correct, if everything is normal. A short PR, less than 0.12, okay, may be seen if an electrical impulse originates in an ectopic site, like in the AV junction. It shouldn't. It should originate in the SA node. Okay, not atrial, SA. Okay, so short PR intervals could be if an junctional ectopic foci becomes irritable. How about a prolonged PR? Greater than 0.20, greater than one big block. Okay, a big block has what? 5 little blocks across the bottom and 5 little blocks high. Well, if you have a prolonged interval, it could mean some type of a heart block. Okay, and we'll talk about some later where you get a prolonged PR interval. Okay, how about the QRS complex? Where's it measured from on 2? What does it mean? Well, it's measured from where? The beginning of the Q or the beginning of the R to the J point. Okay. And the QRS should be 0.10 or less. Like 0.08 is normal. Okay. 0.10, normal. Okay. And we're going to see some QRSs that are prolonged. Normal QRS is predominantly positive in lead 2 with a duration of 0.10 or less. All right. Now remember, the QRS could be negative too. Not always positively deflected, but negative. Now I'm going to throw something in here, and it's a concept that you're going to see a little bit later. I don't know when. Did somebody say final? No. But it's a concept you're going to see a little bit later. Okay, and here it is. Here it is. I'm going, where is it? I think I've misplaced it. All right. It could be negative. Let me give you a quick concept and then I'll get off of it and I'll talk about more of it when I hit on it. But axis, A-X-I-S. Axis is the direction of depolarization. Let me say it again. Axis is the direction of depolarization. And it's represented by an arrow called a vector, like a pointer. And how is depolarization normally moving? Downward and to the left. Let me say it again. Downward and to the left. How do they describe the heart? Size of your closed fist. Once again, unless you have some pathology like congestive heart failure, and part of the heart is really enlarged. But normally, axis moves downward and to the left. Okay. Now, how do you know it's doing that? Well, you've got right chest leads, left chest leads. Well, let's think about that. When you go to the V leads, right? V1 and V2 are the right chest leads. V5 and V6 are the left chest leads. So if you get something in V1 and V2, how's depolarization? Moving downward and to the left, not upward and to the right, all right? So V1 and V2 are kind of negative. V5 and V6 are mostly what? Positive. V3 and V4, I didn't forget those, are kind of down the center, what's called the interventricular septum. Septum, S-E-P-T-U-M, is wall. So directly between the right atrium and the left atrium, okay, is a wall. And it's called the atrial septum. And between the right ventricle and the left ventricle is a wall. It's called ventricular septum. Now, sometimes walls have holes in them, and that's not good because you got a mixing of blood. Remember, you got oxygenated blood on the left and deoxygenated blood on the right. So you could be born with what? An ASD, an atrial septal defect, which means what? There's a wall. There's a hole between the right atrium and the left atrium. Or a VSD, ventricular septal defect, which means there's a hole in the wall between the ventricles. Okay, that's not good. That has to be taken care of. All right. If you take a look at page 14, you'll notice an inverted P in the EKG strip, Bravo, B. You got an inverted P. And notice something about that strip. You can't tell a lot about it because you don't see the other side of it. B. Notice that beat comes early, right? It comes earlier than expected. So we call those beats premature. And sometimes we say, there's a PAC. And what does that mean? Well, it's something you put on your arms through and you can carry it around and carry. No, it's not a backpack. It's a wave that comes early, right? Earlier than expected. So the rhythm is kind of broken up. It's not spaced out, right? And one way you tell whether rhythm is regular is by going P to P, and all the P's are to march out. You got to be able to take your calipers and spread them out, right? Here's one P, here's another one. And you got that much space, and then you go to the R's, and the R's ought to space out. So P to P ought to space out, R to R ought to space out. Okay. And then what? Then you know the rhythm is what? Regular. Now we see the ST segment, and the ST segment represented by early ventricular repolarization, okay, which is a flat line between the QRS complex and the T wave. And the T wave does what? It represents ventricular repolarization. Now I want you to go over real quick to page 19 and look at that QT interval, beginning of the Q till the end of the T. Okay, and notice something about that strip, that Bravo again, that strip that we're looking at, B. Notice one thing right away, that the ST segment is kind of negative. It's below the baseline or the isoelectric line. Not a lot, but a little bit. And then we have some inverted T waves, upside down T waves. Well, where do inverted T waves usually come from? They're junctional. Then we have what's called the QT interval, beginning of the Q to the end of the T. Beginning of the Q to the end of the T. Generally speaking, the normal QT interval should be less than half the R to R interval. So if you know what the R to R is, if you go from one R to the next and you count the number of little blocks between them, okay, the QT ought to be half. Now, why is that? Because if you don't let it be half or greater, right, you're stretching out the relative refractory period. And that could be a problem, a very significant problem, because that relative refractory period is not one to stretch out. You don't want to have it stretched out. You want it to be in within normal limits. Okay, I'm looking at the U wave, PQRSTU. The U wave usually represents, it's small, not big, it's small, and it usually represents later stages of ventricular repolarization. And it's called the U wave. Now, the presence or the absence of the U wave doesn't make a bit of difference at all. If it's present, does it tell you something clinically? No. How about if it's absent? No. Okay, so is it a big deal, the U wave? No. But you should know how to measure it and what it represents and what's normal and what's abnormal. Cardiac monitors over on page 24 and 25. I think you can read it just as well as I can. But on page 26, notice what they're sticking on patients. Applying an electrode pad, a little sticky pad. How does this electrical energy get to the pad? Because it goes from, deep within the skin to the surface of the skin, and the pad can pick it up. And then it's transferred over to the machine. What is a machine? The electrocardiograph. Okay, now we come to analyzing a rhythm strip, and we're gonna call it a day here really quick. Analyzing a rhythm strip. Number one, is the rhythm regular or irregular? That's all I want to know right now. Is it regular or irregular? Okay. Number two, I want you to know the rate. Calculate the heart rate. And I gave you several ways you could do that. What did I tell you to do? Well, you could find an R that peaks on a heavy black line. Do not count that line. Okay, so find an R wave that peaks on a heavy black line. Do not count that line. Go to the line to the right of it and keep going on heavy black lines. 300, 150, 100, 75, 60, 50. 300, 150, 100, 75, 60, 50 is one way to calculate rates. Okay? So we can calculate rates all the way from 300 down to what? 50. We could also take the number of little blocks between R waves and divide that into 1,500, okay, and get a rate. All right? Over on page 35, it says what? Down at the bottom right, identify and examine P waves. I'm trying to move. I didn't think I was actually going to be this long, and I apologize. But you know what? Maybe this helps you. Maybe it doesn't. I don't know. All right. You're going to identify, bottom right, page 35, and examine P waves. Number one, do all the P waves look alike? Because they should. Telling you what? They're all coming from the same focus, the same area. Number one, are they going the same direction when you look at them? In other words, do they look different? You're going to measure the PR interval, beginning of the P to the beginning of the R, 0.12 to 0.20 seconds. So when you examine a rhythm strip, when you do analysis, number one, is a rhythm regular or irregular? Just put that down. Examine. Number one, is a rhythm I see regular or irregular? Number two, what's the rate? Why? Because rates can help you identify where it's coming from. Then you're going to examine what? P waves. Do they all look alike? Then you're going to measure what? PR, 0.12 to 0.20. Then you're going to what? Measure the QRS. Is it 0.10 or less? Then it's normal. But you're going to look at all this to what? To say this is where it's coming from. All right, tell you guys what. We're going to pick up tomorrow on something called sinus arrhythmia. And if you want to read ahead a little bit, page 44 and 45. Sinus arrhythmia. But do me a favor before we leave. Take a look at page 45. What's it say? Does it say it's abnormal? No, it says NSR. What does that stand for? Normal sinus rhythm. And take a look what they wrote there. Figure 6.2. The rhythm, regular. The rate, 79 beats per minute. The P waves, they're sinus. The PR, 0.16 to 0.18. The QRS, 0.06 to 0.08. So is everything kind of normal here? And the answer is yes, it is. Okay. Now, when you say normal sinus rhythm, you could also say RSR, regular sinus rhythm. I like NSR. Either one of them mean the same thing. NSR, normal sinus rhythm. RSR, regular sinus rhythm. Okay, you guys have a great evening. We're going to pick back up tomorrow on page 44. I'm going to set some new quizzes this week online. I'd like you to do those. I'm giving you extended periods to get this done. If you know of somebody that is kind of going, oh, I don't know if I can get this, yes, you can. What did I tell you? Kennedy told us, one of his crew members, you can do your job. Thank you, guys. God bless. Have a nice evening.